Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical again. And we're doing the 2 weeks free session right now. And actually, we are at the end of the 2 weeks free session. So we have this class, and then there is another class on Saturday, which is mainly focusing on pediatric cluster. So in that way, you will also have some idea about how to approach pediatric history, investigations, physical examination, all of them. Now we have done cardiology throughout this 2 week session, and also you have finished psychiatry MSc with us, which means like you already finished 2 important topics for AMC clinical in just 2 weeks time. So it's a very good approach, as you can understand. And also you get to know the approach, history, physical examination of medicine, because we will follow the similar approach throughout the whole medicine clusters. So we did a role play session for psychiatry. We did have a random role play session with Dr. Cynthia. And today we are going to have another role play session, which is mainly on cardiology theory that we have done. Now, when we do the role play session after finishing a particular topic, we try to refocus on what we have learned in the theory session. And also we try to add some new cases so that this class is not just role play session, and also you will get to know some new cases as well. So in that way, this class has some information which you don't know at the moment. So some cases we will be doing, which already has been done in theory class, and some cases we will do, which we haven't done yet. So that's the plan. So let's start. Who wants to do the first role play? And as I say that I would like someone who hasn't done role play yet, so that everyone gets the chance to do role play. Okay? Okay, so Dr. Shamalika, you can unmute yourself.
Hi, Dr. Arshan. I'm Shamalika.
Hi, Shamalika. How are you?
I'm doing great. Dr. Arshan, how are you?
I'm good. I'm good. Thank you. So you want to do the role play?
Yeah, sure.
Okay. I'll give you the case. Now, for everyone, that remember that we haven't done one particular case, which is the CVS risk assessment. We will do it at the end of today's session. Okay?
Okay.
All right. So you will get 1 minute time outside to think about, and then
Okay.
7 seconds for your role play.
Sure.
So this is your case. Your 1 minute time just started. All right. So your patient name is Adam. You can start.
Hello, Adam. I'm Dr. Chamalika. I'm one of the doctors here. I'm here to help you today. How are you today?
I'm good, doctor. Thank you.
Okay, I gathered from my note that you have had recurrent falls for 2 consecutive nights. Could you please tell me how are you feeling all right at the moment?
Yes, doctor. I'm fine now.
Okay, if you could excuse me for a minute, I would like to talk to my examiner and get back to you. Is that all right?
Yes.
Okay, dear examiner, I would like to know that the patient is stable enough to for me to proceed with the history. How is the patient's blood pressure in the sitting as well as the standing position?
Please stick to the task. Move on.
Okay. Adam, I would like to know some extra information from you. Is it all right with you?
Yes, doctor.
Okay, Adam. Could you tell me what happened during the last 2 nights? First, we'll talk about the last night first.
Yeah, actually, for the both nights, what's happening is that you need to wake up multiple times at night to go to the toilet, and because I'm doing it abruptly at that time, and it's very dark, and I just get very dizzy, and I had the fall.
Okay. The same thing happens both the times, right?
Yes.
Okay. So it mainly happened when you were sitting up or standing up from the lying down position, I gather, yeah?
Yeah, it's just like whenever I'm just getting up in the nighttime, I just feel dizzy and I fall.
Okay. So you feel dizzy at that point, and how long? Do you feel any loss of? Have you had any loss of consciousness at the periods, or were you all right?
I was all right, but I did not lose consciousness.
Okay. Did you have any associated features like any chest pain, any difficulty in breathing, as such?
No.
No. Okay. Did you did you pass any urine at the did you have an urgency to pass urine? Did you pass urine at the bedside itself, or did you feel like you were you were having jerky movements or any biting of tongue like that?
No, doctor.
Okay. Have you had any weakness in the body or any fever or rashes in the recent times?
No.
Okay. Did you have any head injury from the falling or before the fall?
No.
Okay. Do you have any bleeding episodes like bleeding while you're passing urine or while you're passing stools?
No.
Okay. Do you have any burning type chest pain when you are which is associated with meals?
No.
Okay. Do you feel generally tired these days?
No.
Okay. I guarantee you that what is to pass between us will be between us, and I'm asking these questions to help you. Do you have any stressors at home at the moment, or do you work? Do you have any stressors going on at the moment?
No, doctor.
Okay. How is your living condition? Do you live with your family members? Any family members? The housing conditions?
I live alone, doctor.
So live alone. Okay. How is your, do you have any illnesses for which you are taking medications like diabetes, hypertension?
No.
No. Okay. Are you taking any medications for anything as such?
Just take some vitamins.
Vitamins. Okay. Do you know the names? So
No, doctor. Just over the counter some vitamin D and E tablets.
okay. And what is the condition like from your bed to the washroom? Are there any slippery carpets or any loose railings or such?
No.
Okay. Do you have any difficulty in seeing, Mr. Adam? Any difficulty in your vision?
Not too much, but I just need to wear glasses for reading, but not much.
Okay, so in the night when you have these falling episodes, do you feel like it could be due to your poor vision?
I don't think so, doctor, because I can see clearly in the detail.
Okay, okay, okay. Have you ever checked your blood pressure or blood sugar?
No.
Okay, do you smoke or use alcohol or any other recreational drugs?
No.
Do you have any family history of heart diseases, diabetes as such?
No.
Okay, okay. And you live alone, right, Mr. Adam? Okay. At the moment, thank you so much for your cooperation. I would like to go to my examiner at the moment. Is that okay?
Yes, doctor.
Okay. Dear examiner, I would like to examine my patient. First, I would like to start with the general examination. Does he have any pallor?
No pallor.
Okay. Does he? I would like to examine his neck. How is the jugular venous pressure? Is it pulse? Is it elevated? And whether there are any bruise in the neck?
Negative.
Okay. And then I would like to do a cardiovascular system examination in the patient. First, I would like to start from pulse. How is the pulse, the rate and the rhythm?
Pulse rate is 80, rhythm regular.
Okay, and the blood pressure, sitting and standing position?
Sitting 140 by 80, standing 110 by 75.
Okay, okay, and then I would like to do the cardiovascular system proper examination. How is the apical pulse? Is it in the on inspection? Is the apical pulse the pulsations are there or not?
You can't see any visible apical impulse.
Okay, okay. On palpation, is the where is the apex and are there any thrills or parasternal heaves?
I'm up. Thank you, doctor.
Okay.
All right.
I'm sorry.
My
time.
That's okay. Yeah, I know. Like this history is quite long. So if in such cases it has to be like very fast. But you did good, Dr. Chamalik. I would say that your approach, you are doing really great. It's just like you need some more practice with more role play. You will be fine, I know, because you have that confidence in your voice and your approach is very nice and gentle. Everyone will love it. So what you just need to work on is that you should just practice with your role player or with your steady body to do it more quickly. And like also like you have been thinking in your head that what you're going to ask next, and that's killing your time. So when you will do this kind of cases 2 or 3 times, you will not think because it will come into your head. So in that way, your time will be fine. So let's say if I say that if I ask you to continue the physical examination, just finish the examination, like your cardiovascular system is normal, and then just go on.
And then I would like to do a nervous system examination, upper limb, lower limbs, and then cranial nerves as well. And then abdominal examination and respiratory system examination to clear up my examination. Okay, then I would like to, that is my examination. Then the differential diagnosis are various in the.
Do you want to do anything else? Do you want me to ask anything else in the physical examination? Because your diagnosis will depend on that.
Whether he's having any numbness in his feet.
No?
The
office test.
Endoscopy and
ask me the office test.
Sorry?
Office test, like a bedside test. Yeah. Okay.
The
so
blood
your
sugar level
examination is not over if you don't ask the office test. So always, like if physical examination is a task in the exam, finish
Yes.
with the office test. Doctor, is there any
Okay.
office test available?
I would like to do a urine dipstick, blood sugar level, and an ECG as well.
Okay, so ECG is normal. Your patient's blood sugar is 4.0 millimole per liter. And in the urine dipstick, you have found patient have positive nitrite and leukocyte.
Okay.
Do you want to ask anything to the patient?
Sorry?
Do you want to ask anything to the patient before you give the diagnosis?
Whether he has any urinary tract features of urinary tract infection like dysuria.
Good. Yes.
And he obviously has nocturia. So
yes.
The polyuria and frequency.
Yes. Good. Very good. Yes. So you all, yes, that's right. Because you are actually asking that. Remember the first thing that you say, like when you asked, can you describe what's happening for the last 2 nights? I'm saying that whenever I get up in the night time, because I'm having a lot of pain at the moment. So if something happens for 2 nights, which should be something very acute, because I haven't, and you could ask that, is this the first time you are having this kind of fall, or did you have it before also? You will know then, no, doctor, it's the first time I'm having it. So something acute like this, obviously, like it might be some infection or something which can cause acute fall, you can think about. So like that was the clue that I need to get up by a lot of time at the night time. So when you get something like that, everything in the presenting complaint given to you, it is for a reason. Always remember that. And I say that you might not get similar kind of questions in the exam, because exam always give you something very new, which you might not even predict. Like this UTI causing fall in a 70-year-old man, it's not actually very commonly asked. But see that it's a very important case also. So whenever you should always think at the exam for everyone. It's not for Dr. Chamarika. So it's for everyone. Like if you get something at that time, don't just think that, well, these are the cases I know, and this will always be the same thing. If you get like nocturia, ask urine conditions, because you will get everything. If you just ask one question, how is your urine at the moment? The role player will give you, yes, doctor, I'm having burning sensation. I'm going to the toilet more than often. I have to get up multiple times at night time. So that's cystitis or urinary tract infection. An infection itself can give postural hypotension in a patient. Remember, one of the cause of postural hypotension was infection, because this patient, you can't find out anything. The patient is not taking any blood pressure medication, no medication. Patient is not diabetic. So what is causing this fall? So you need to then explore that. What I have missed, something is obviously there which I'm not getting. So that's the thing. And also, if you would ask me that, like, do you skip your meal at night time? Then I would say yes, because my the blood sugar was 4, which is not very good blood sugar level. He's actually touching the hypoglycemia. So less than 4 is hypoglycemia. He's having 4. So most likely he's also skipping meals at night time, which you might get. So all the format you have, it is there for a reason. So when you have got like, yes, I feel dizzy when I get up at night time, that means it's a postural hypotension. So then you try to find out what are the causes of it. So is it the medication? Is it related to any recent infection, any severe vomiting, diarrhea, electrolyte imbalance? So we need to go to find that out. If you don't get medication, then it's something else. Okay.
Okay. Right. Thank you so much, Dr. Arshan. I learned a lot.
No worries. That's all right. That's why you are here. But that's good. You are doing really good.
Thank you.
I would say that in here, in the recurrent fall cases, always open, like always have an open thought in your head that it can be anything, because a lot of questions come from here. So obviously, I would say that first start how Dr. Chamalika started. Obviously, greet with the patient, reassure the patient, make sure if he is stable or not. Then ask about the fall history, what exactly happened. So we always follow like what happened before fall, during fall, and after fall. So you could always ask that, like, what happened before fall, right? Did you feel any headache, nausea, vomiting, any blurring of vision, any weakness, any chest pain, any difficulty breathing? And then, did you lose your consciousness? Was there any weaknesses? Did you hit your head? Rule out all the epilepsy questions. Then ask about post-fall questions. Then go to the differential diagnosis. And you know all the differential diagnosis that we talked about. I'm not going to discuss it because we will do some other fall cases so that you can remember also. So all the differential diagnosis of falls we will ask here. When we get that it might be a postural hypotension case, then your main focus would be to find out the underlying cause, which is not very, like, not a large number of causes. So you might get recent medication or any increased dose of any medication. You might get sepsis or infection. So ask about fever, rash, nausea, vomiting. Ask about head-to-toe question, like any difficulty breathing, any chest pain, any abdominal pain. How's your urine habit? How's your bowel habit? So you can always ask, say, a systemic question if you are not finding any cause. This is one of the tricks I always used to do. And I always ask my candidate to do that. If in the exam you don't get positive finding which you are looking after, your last weapon is to do a head-to-toe systemic question. That means what's in your head. So symptoms of the head is headache, nausea, vomiting. Then what's after that? Upper respiratory tract. So any runny nose, any cough, any sneezing. Then lower respiratory tract. Any difficulty breathing, any noisy sound from your chest, then any chest pain, that's your cardiovascular system, any racing of your heart, then GIT, any abdominal pain, any nausea, vomiting, how's your bowel habit, how's your water work. If you do that, you will get some finding in that way. Okay, so that's your last weapon if you don't get any finding what you're looking after. Once you have done that, then obviously you will finish with SADMA, past medical history, family history and support, and also the home situation. Physical examination, as we do always, nothing different from what we have learned already. And in this case, the diagnosis would be a couple of things. That patient having postural hypotension, discuss what is postural hypotension and say that most likely you are also having a urinary tract infection because you are having the symptoms of urinary tract infection, and also in the urine test, we have found some infectious cell. So we are going to send this urine to the lab to confirm the diagnosis and find out which bug is causing it, and we will treat you accordingly. Now, when you have infection, sometimes that can also lead to the low blood pressure, especially when you change your position. So, and also as you are skipping meal at night time, you might be also getting a little bit of low sugar at night, which might add to your recurrent fall history that you have given for the last 2 nights. Okay, and then give the differential diagnosis. Cool. So that's all about this case, guys. Any question? No question? All right. So who wants to do the next case? After Dr. Chamalika, then Dr. Luzhel, you wanted to do? Yes, please unmute yourself.
Good evening, doctor.
Good evening, doctor. How are you?
Fine. It's my first time to do the role play.
Yeah, that's all right. You will do fine. Your voice is like a little bit of breaking. Can you say something again? Like just say
Hello,
that you.
hello, doctor.
Yeah.
Is it any good?
Yes, it's fine now. It's all good.
Okay.
Okay. I'll give you the case. Just give me a minute, please. So we will do this case like online examination. Okay. So follow the online examination format in here. That means that you can't ask anything from the examiner.
Okay, no.
So this is your case. Your 1 minute time is started, and then we will start your case. All right, doctor. So your patient name is Jessica. You can start.
Good evening, Jessica. My name is Dr. Lucille. I'm one of the doctors here in the ED. How are you?
I just don't know, doctor. It's just I can feel my heart is beating, and it's not a very good sensation. I'd never had it before, so I just don't know like why I'm feeling like this, and I can't stop it.
Okay. So, Jessica, can you tell me what happened before you experienced the racing of the heart as what you have said? Were you doing anything?
Yeah, I was just like walking by the road. I was not doing any exertion or anything. It's just started all of a sudden.
Okay. So, what did you do to relieve the condition? Did you take any over-the-counter medications?
No, I sat on the bench on the road. I tried to take a rest, but it did not help. So I just came to the emergency.
Okay. May I know more about this? Are there any associated conditions that arise when you felt the racing of the heart? Were there any chest pain or like a feeling of fainting or maybe like the feeling of about to collapse?
I feel lightheadedness, but not chest pain.
Okay. So just to clarify, Jessica, this is the first time that it happened, right?
Yes.
Okay. So may I know if you have any medications that you are currently maintaining?
I was given a hypertension medication by my GP, but I
Okay.
forgot which medication it was, and I could not take it.
Okay, so you are hypertensive.
Yeah, my GP told me that.
Okay. May I know about the blood pressure, like the average blood pressure?
I don't know, doctor. Sorry.
Okay. So apart from hypertension, were you diagnosed with any other illnesses such as
No,
diabetes, like a thyroid trouble or a kidney
no,
trouble, heart problems before?
no.
Any previous hospitalizations or surgeries?
No.
Okay. So may I know if you smoke or drink alcoholic beverages?
Yes, I smoke, but no alcohol.
Okay. What about the use of recreational drugs?
No.
Okay. So Jessica, um, were you able to, I mean, do you have any family history of a heart problem?
No.
Uh, okay. So may I know about your current occupation?
At the moment, I'm not doing any job, doctor.
Okay. So do you drink a lot of coffee?
I drink like about 6 to 8 cups of coffee.
Okay. So when you, is this the first time that it happened? I mean, in the past, even if you drink like 6 to 8 cups of coffee, it did the racing of the heart did not occur.
It's actually I increased the amount for now because I just feel very tired, and whenever I have the coffee, I feel energetic.
Okay. Okay. So examiner, I want to proceed with the physical examination. Oh,
Okay, doctor.
sorry. May I know about the general appearance and the vital signs of the patient?
Stick to your task, doctor.
Oh, okay. Um, okay. Thank you, Jessica, for the information. Now, I want to get the investigation from the examiner. Hello. Okay. Okay, thank you. Um, Examiner, I think that the patient is currently suffering from atrial flutter. Basing on the ECG, um, the rate is above the normal, which is about 150 beats per minute, and it is irregular. And there are no P waves, and the QRS is narrowed. There are no ST elevations, but um, it's most likely atrial flutter due to the absence of P waves. That's why the patient is having palpitations. Atrial fibrillation rather, not atrial flutter. Atrial fibrillation. Okay, so Jessica, I will explain to you the diagnosis. I know that this is stressful for you since this is the first time that it happened, but I want you to know more about your illness, and this is called atrial fibrillation. Atrial fibrillation happens when some electrical impulses in your heart is not uh, is not within the normal is not normal. Okay, I will draw a diagram. This is your heart. It has electrical impulses inside the heart, which regulates your heart, which regulates the heartbeat. So what happens in atrial
Uh-huh.
flutter is
Go on.
okay. What happens in atrial flutter is that there are many there are the electrical impulses in the heart, is not synchronous, and that's why you feel palpitations. However, we can one thing that that exacerbates this is your is this the huge amount of coffee that you are currently taking. You drink about 6 to 8 cups. So if we lower your caffeine intake, this can resolve, but of course with the help of medications. I will review you uh in a week time maybe, and then to see if you have any, if there is any improvement after being after taking down your caffeine intake. However, I want you to understand that there are also red flags that we should watch out, such as the feeling of fainting, um, yes, feeling of fainting, or maybe or syncope, and then chest pain that radiates to the jaw and to the arm, and also
Thank
if
you, doctor. Time is up. All right. Okay, you did good, right? So it was good. It's just like, I think the timing was not perfect, but yes, the way you did it, it was not bad. But I feel like you have to go through our previous session on the atrial flutter or palpitation cluster. And if you just do role play after going through that class and going through the notes, it will be much better. Why I say that is that, like, your approach is fine, everything is fine, but you are doing the same mistake which every beginner will be doing. So that means that still you have more things to learn before doing anything else, which means that first thing, you need to go through the notes that we have provided, and mainly the class that we have taken for the palpitation. Go through that and remember what are the differential diagnosis of palpitation, because in your history there was not much differential diagnosis, right? So always remember that it becomes very easy to ask the past medical history, smoking, those kind of things everyone asks, but they forget the differential diagnosis. And examiner easily can understand that if you are beginner or if you have been doing it for a long time, just by this, because beginners usually remember the history of presenting complaint. They ask the presenting complaint, nice and easy, and then directly jump to medical history. And they don't ask any differential diagnosis at all. Always remember, differential diagnosis is the most important thing in your history. There is nothing much important than that, because the examiner wants to know that if this candidate knows what are the differentials for having a palpitation. We have a lot of differential, right? CVS causes, CNS causes, we have electrolyte imbalance, endocrine causes like thyroid, pheochromocytoma, lot of things. Then infection. Remember all of those? So those will come in here. So you have to ask every differential diagnosis. And then you come to the medical conditions, history of SADMA like smoking, alcohol, recreational drugs, tea, coffee, family history. So those are at the end. Okay, and what is very important for a middle-aged woman who is having palpitation?
menstrual history.
Yes, because this patient might be in a perimenopausal phase. We don't know that, right? So you have to ask menstrual history. So that's about the history. Then also, even if it's an online exam, you can always say that, hi, Jessica, this is Dr. Liz Hale, one of the doctor in this emergency department. It's very nice to meet you. I got to know from the notes that you are having palpitation for the last 2 hours. Are you still having it right now? Yes, doctor. I'm very sorry to hear. But now that you are here, don't worry, we are going to take care of it. But the first thing that I'm going to do is to check your vitals. I can already see from the notes that your vitals are stable, so I'm happy to proceed. See that it's already given in the stem, so that's good that you haven't asked it, so that's all right. And then you can ask, can you tell me a little bit more about what exactly happened? So then the patient will give you the information. You will ask that, is it for the first time or not? How long it's been going on? So that's fine. Your HOPC was all good. Once after that, you ask the associated chest pain, lightheadedness, which you actually asked also, but you just missed all other differentials in between. So history was fine. Next is the other thing I wanted to say, that do not go to the examiner without saying something to the patient. What you have done, that
Yes, I forgot about.
yeah, like you jump to examiner, but I was like, what happened? Why doctor went to examiner? Okay, so always say thank you so much for giving all the information. I'm going to talk to my examiner now and then come back to you. This way, this sounds more gentle, and otherwise they will just mark you down for approach. So after that, obviously this is an online format, and see that your task, there was no physical examination. So that's also important, knowing your task, because it's already on the screen. Online exam, you get it on the screen, but in face-to-face, you don't get it on the screen. So you have to remember the task at that time. So it becomes hard. So this part is important, because if you do physical examination and it's not your task, they will not stop you. Okay, they might not give you any information, but they will just keep on doing that. So you will not get any mark, and you will also waste your time. So make sure that always remember what is your task. And then if the task is like get investigation from examiner, don't say that I'm going to get investigation from the examiner now. Say that which investigation you want to do. Say that, dear examiner, can I please get the ECG for my patient? Okay, so that becomes more better. And then examiner gives you the ECG, and you explain ECG to the examiner. So when you explain the ECG, you follow the format. So in this case, it's more, you can see that it's an irregular heart rate. Now, it will be a little difficult to say it is the atrial flutter or fibrillation, but in some states, if you see here, this is more flutter, this is more fibrillatory wave than sawtooth appearance. Same here, same here. If it was a flutter, it would be like this. You will see the sawtooth appearance very prominently. So I would rather say it's atrial fibrillation rather than flutter. So you will obviously use the format, like the heart rate is increased, rhythm is irregular, there is no visible P wave, which has been replaced by fibrillatory wave. QRS complex is normal or narrowed, whatever you say, it's fine. There is no ST wave changes, no T wave inversion or changes. QT interval is normal. Okay, so, and then you can say that most likely it is the ECG of atrial fibrillation. And then you explain the diagnosis. We actually discussed how to explain atrial fibrillation to the patient in the class. So follow that format. And what is the implication of AF? Mainly two implications, stroke and heart failure. Okay. So stroke and heart failure is our main two implications for AF. So that's how you finish this case. Any question for anyone? Thank you, Dr. Lucia. And Dr. Bithi, the notes actually is only for our, so once you join the course, then you get the notes only. The implications are stroke and heart failure. All good. So see that even if we know the cages, still sometimes it might be really hard. So that's the reason why I always say that you have to do role play with your study buddies. So for those of you who don't have a study partner yet, make sure you get one. I always say that it's a good idea to get a 3 partner, because sometimes if you have only 2 partner, like one of you is like you as one person, and then there is another. So if it is a two-partner group, then it becomes sometimes irregular, because one day you will say that I'm going for a date night. I'm going for watching a movie. Another day your study buddy will say, no, today I'm very sick. So in that way, it will become irregular. If you have another person, then there's a way to maintain stability in the group, because if you and your other partner do the role play, the other buddy who keep skipping the session, she will eventually come and join you, because she will just miss the session if she doesn't come. So in that way, it becomes a stable group. So 3 partner is the best. Don't have more than 3, don't have less than 3. Okay. Now, obviously, once you join our course, you get to see a lot of people from all around the world. You get your partner from the course mainly, because we try to make sure that for those of you who don't have partner yet, we will try to find out your role player according to your time zone. Like if you are in Australia, we will try to find someone who resides in Australia so that your time zone becomes similar. We will give you those time zones, but you have to approach your partner. That means I don't know that who you would like to have a partner. You have to show your interest and send the message to them that, well, you and me are both in the course. Can I be your partner? Because your time zone is similar like mine. So can we start doing something like that? So this is the way that we normally do. Okay. So once the 2-week session is over, I know that many of you are already enrolled in the course. So we will just start that process after this week is over. Okay. Yes, doctor. And obviously, if you are in the course, you will get the notes from our portal. So the portal is already opened. We will show you how to enroll or how to get into the portal. Just let's finish the 2 weeks free session, and then everything will be clear for you. Okay. And Dr. Bithi, if you haven't been subscribed to the software yet, please send me a message in my inbox. Just make sure that, to tell me that I'm still not in the software, how I can get access. Okay, I will show you the way. And then there is obviously a video given in your course group already. You can have a look on the video and do it by yourself. Okay, so let's not move in that direction now. Let's do some more. So who wants to do next? And Dr. Tithi, yes, for atrial fibrillation, we should know the treatment, because treatment of atrial fibrillation comes in exam. I discussed a little bit about it in our session, but just make sure you know about it. So after Luz Hale, there was Dr. Tithi. So you want to do the role play?
Hello, doctor. Yes.
In our last session in psychiatry MSc.
Sorry, doctor.
Did you do the role play in psychiatry MSc role play?
No, doctor.
Okay. All right. So let's do the role play now. Now we will do a new case, Dr. Ismotara. Fine with you?
Yeah, doctor. Let's try to.
Yeah. So this is your case. Your 1 minute time started.
Okay, doctor.
All right, so this is your patient. Your patient's name is Sam. You can start.
Okay, doctor. Hello, I'm Dr. Ismodara, and I'm the working doctor in this GP clinic today. Hello, Sam. Nice to meet you.
Nice to meet you, doctor.
So, Sam, how are you going today?
I'm good, doctor. How are you?
Yes, doctor. Yes, Sam, I'm fine. Thank you. So, Sam, do you have a specific concern for today's video?
No, doctor. I have seen by one of your other doctor in the practice, and he asked me to check my blood pressure at home, which I have done. And this is actually my blood pressure. It's in between, most likely 140 by 90 to 150 by 85. I've checked it for the last 1 week, and this is actually my average. So I just want to discuss about it.
Okay, Sam, thanks for your initiation and effort to visit with me. It's a great initiative. Sam, I'm going to discuss with you regarding your condition that you have observed your blood pressure for a whole 1 week. Now I'm going to discuss your condition and necessary things that I should talk to you. So, Sam, you have observed your blood pressure at home, and the recording become between 140 to 90 over 150 to 85. So it's a bit high from the normal range. So I'm going to discuss with you regarding the another method that is called ambulatory blood pressure monitoring. So do you ever heard about that?
No, doctor.
Okay. So Sam, can I ask you some question? Is that all right for you?
Yes, doctor.
Sam, are you taking any antihypertensive medication now?
No.
Okay. So are you feeling any chest pain, sort of breath?
No.
Any difficulty in difficulty in seeing anything?
No, doctor.
Okay. Any problem with your urination?
No.
Any headache, blurring of vision?
No.
Okay, that's great, Sam. So, Sam, you have monitored your blood pressure. Are you taught by any blood pressure monitoring educator?
No, doctor.
Okay, so are you taking your blood pressure at the same time and with ideal position?
Yes, I'm actually doing it in the morning, and I'm just sitting upright.
Okay. Okay. So Sam, sometimes blood pressure monitoring at home is usually taught by a blood pressure monitor educator or a trained nurse. They will show you the ideal procedure how to monitor blood pressure properly at home. And sometimes, like the blood pressure monitoring can be influenced by different factors, like when you monitor your blood pressure at home, it's become normal sometimes, or sometimes it get high from the normal range. And when you visit at the doctors or any other hospitals, sometimes it get again high, or sometimes it's normal. So it's sometimes like different factor that happening to influence your blood pressure monitoring. That's why we need to continuous monitoring of your blood pressure to know the exact blood pressure of you. So that's the indication for discussing with you regarding the ambulatory blood pressure monitoring. So this is the device that will be inserted with your body, that continuously monitoring your blood pressure throughout the day, and in a certain time period that will record your blood pressure. And if there is any significant change happen to your body, and if there is any significant fluctuation of your blood pressure, it will recorded it, and we can get the exact result. Are you understanding me so far?
Yes, doctor.
So to find out the exact blood pressure, if there is any specific like change in blood pressure, that's why we need to monitor your blood pressure through the ambulatory blood pressure monitoring device. Are you understanding me?
Yes, doctor. So this device is going to be inserted in my body. So how they're going to insert it?
It's just not like to insert your device. It's like a device that will be attached with your body, and it's a very light device. It will not feel like any heavy things you are carrying or any hassles you are facing. So there is some specific implication. That's why we need to monitor your blood pressure, because the recording you came with me, it's a bit high from the normal range, and there is some specific indication, because high blood pressure is not, if not controlled within time, it can causes some notorious things to you. Like sometimes high blood pressure leads to stroke. That can be a life-threatening condition. It can sometimes cause nasty to your heart functions, that sometimes lead to heart attack as well. It has a bad effect to our vision, that is called because high blood pressure causes hamper to the blood circulation to our eye as well. That's why you feel sometimes blurring of vision, and a vision problem as well. The high blood pressure has a bad effect to our kidney. Are you understanding me so far, Sam?
Yes, doctor.
Sometimes high blood pressure causes our nerve function, hampering to our nerve function as well. That's why we need to monitor our blood pressure and control it in time by lifestyle modification and with some medications. Do you have any questions so far?
No.
Okay, so Sam, to manage your condition, I needs to do some further investigations to find out is there anything bad happening to you already or not, or and some necessary basic blood investigation, like I want to do full blood examination, urea creatinine electrolyte to assess your kidney function. I need to check the creatinine level, electrolyte level, to monitor your heart function. I need to do the ECG and relevant investigations as well. If there is any abnormality, find out. I need to check your and already you have done fundoscopy that showed a grade 1 retinopathy. That can be the complications of a high blood pressure as well. So in that case, we have to definitely control your blood pressure urgently, and I need to refer you to the ophthalmologist for further evaluation, and how can you control for further progression of your retinopathy. So I
What's
also check
retinopathy, doctor?
Okay, Sam, thanks for your nice question. So retinopathy is this is an abnormality that's related to your visual part of our eye. That is responsible for our vision. So due to high blood pressure, sometimes the blood circulation to that part of our eye is become hampered. That leads to a vision problem. Doctor, I should proceed. Okay.
Time is up. You want to do anything? Like you finished actually everything. So is there anything else you want to do?
Another investigations, Doctor, at that moment, I cannot remember actually.
No, that's fine. Actually, you did really, really good. Given that we haven't discussed this case, you did really great. Okay, so let's discuss about it. I will show you that, like, if there is anything else that you can add here, but I'm really happy that you told about the fundoscopy result and you send the patient to an ophthalmologist. That is one of the key steps in here. And if you don't do that, you would miss one step.
Okay, thank you.
Now, that's one of the things, like, do we need to do any investigation to rule out secondary causes? Now, according to the Heart Failure Australia, the guideline is that not every hypertensive patient needed to have the full investigations for secondary hypertension, because you might end up doing a lot of investigation, which is unnecessary. If a patient gets refractory hypertension, that means you tried 2 drugs with a maximum doses of that, and still you can't control the blood pressure, then normally you go for those secondary causes, like you check the cortisol level, you check the aldosterone level to rule out Cushing syndrome, Conn's syndrome, okay, and pheochromocytoma. So you check the urine VMA. So those kind of investigations are very costly in here. So normally, as a GP, we don't do it for every patient. We only do it in case a patient's blood pressure is not controllable with 2 maximum doses of antihypertensive, which we commonly use. So right now, you don't need to do those secondary causes investigation. Your basic investigations will be just full blood examination. Very important is to check the kidney function, blood sugar level, lipid profile, and also you want to do a ECG, and you can do a urine test to check for any microalbuminuria. So that's the usual investigation. Apart from that, after doing that investigation, if you have to manage this patient, right? So your management depends on the 5-yearly cardiovascular risk of the patient. So that's actually, I was asking Dr. Tithi that you have to say that you want to, after the blood results you have found those results, especially the cholesterol level, then you are going to use a 5-yearly CVD risk assessment chart to see that what stage or what risk the patient is now. If this patient is in low risk, then you can just try with a lifestyle modification for 3 months at least before starting the treatment. If this patient in moderate risk, then again, you can try lifestyle modification for a month or even 3 months. But if the blood pressure is consistently above 160, you can start treatment. And if it is severe, then you can start treatment immediately. So that's why your management depends on the CVD risk assessment of this patient. So you have to just say that management is not a task, so you don't need to bother with that too much, but you might just touch the point that you want to do, you will do further management based on the investigations, and also you will use the CVD risk assessment chart for further assessment and management.
So
Okay,
Doctor,
now,
we have to, just one question. So we have to correlate the investigations finding with the risk assessment, then just related management.
Yes. So for management, you have to do a CVD risk assessment. And remember the CVD risk assessment, how we do it. You need systolic blood pressure of the patient, and you need if the patient is diabetic or not, if the patient is smoker or not, and you also need the cholesterol, the total cholesterol HDL ratio. So once you have all the information, then you can put it in a chart. Now, yes, if it is a very young hypertensive patient, like let's say a 30-year-old having hypertension, then you can do some secondary causes investigation, especially check the renal artery stenosis by doing an ultrasound duplex of the renal arteries. So for young hypertensive patient, yes, you can do some of the secondary causes investigation. But for a 45-year-old, this is most likely an essential hypertension. Dr. Kollol, if patient not on any antihypertensive with still high BP, should we go for secondary hypertension assessment? No need for every patient, case by case. So obviously you will start with your introduction and say that, like, I'm very happy that you are here today. And then start as usual. So, hi, Sam, this is Dr. Arshan, one of the doctors here. I understand that, or you can just say that it's very nice to meet you, Sam. Can I know what is your main concern today? So patient will say, yes, doctor, this has happened. My other doctor wanted to check the home blood pressure. I did that for the last 1 week, and I came with this average blood pressure that you can see. So then you say, it's very good that you have done it. I really appreciate your effort. And let's discuss about your blood pressure now. So what actually happened, Sam, that when we checked your blood pressure at our office setting, it was high. But normally we can't say that you are having hypertension or high blood pressure based on one setting. So, and on the top of that, sometimes the clinic or hospital setting is a kind of a stressful environment for a lot of patients, which sometimes can induce some hormone release from your body, and that can result in a transient rise of blood pressure. But in reality, your blood pressure might be totally normal in a calm, quiet, relaxed environment like at your home. That's why, to confirm that if you are genuinely having a high blood pressure or not, we normally check it in your home, as we can't rely on a single reading and we can't rely on the office setting blood pressure all the time. The next step to assess your blood pressure is to do a repeat blood pressure assessment at the office setting, which we will do today, and also to check your blood pressure at home. Now, I have checked your blood pressure at home, and that is still in the high blood pressure range, which means that it is not normal. Now, in your case, as you are having high blood pressure at home or in your usual relaxed environment, and as well as also here in the clinic, it means that most likely you might have got a condition called hypertension. Are you with me so far? Yes, doctor. But please don't worry. So in here, you have to add some of the other information that in your case, because you are having high blood pressure at home, or even in your usual relaxed environment, and also in the clinic, the next step to confirm the diagnosis is to do another investigation called ambulatory blood pressure monitoring. Do you know what is ambulatory blood pressure monitoring means? No, doctor. Well, let me discuss it in detail. So ambulatory blood pressure monitoring, it's a portable device which is used to monitor blood pressure over a 24-hour period as you continue your normal routine activities. It can be used to detect any blood pressure changes during the day or night time. The test is totally painless, and you might just feel some pressure on your arm when the blood pressure cuff is inflating. The monitor will have an internal pump to inflate the cuff, and a memory card will be inserted to record all of your blood pressure recordings. And then we will see your average blood pressure recordings at your home environment and when you are doing your usual activities. This will guide us to the next step, that if you actually have a high blood pressure or not. Are you with me so far? Do you understand me? Yes, doctor. Now let's say if we confirm that you have high blood pressure, then you don't need to worry about it, because it's very appreciating that you came to us and we could catch it at the earliest stage. But the important thing that you need to remember that this is a silent killer, because sometimes it can cause severe damage inside your body without causing any symptoms at all. As for example, it can affect your heart, resulting in enlargement of your heart. It can even cause heart attack, and eventually it can lead to heart failure. It can affect your brain, may end up getting a bleeding inside your brain known as a stroke. It can also damage your kidneys and also your eyes. Especially, we have done a test called fundoscopy to look inside the back of your eye known as retina. And unfortunately, we have detected some initial changes in the retina. And that is what we have called as a grade 1 hypertensive retinopathy. But please don't get scared about it. It is the earliest changes that happens if the blood pressure left untreated. But now that we know that you have got it, we will take care of it, and we will send you to an ophthalmologist or an eye specialist who can do further management to prevent any further progression of this condition. This hypertension can also damage your blood supply to your lower limbs, and you can end up having significant pain during walking, known as peripheral vascular disease. I'm not trying to scare you, Sam, but these are the possible chances, but as I said, that if we manage your blood pressure properly, then all these complications can be prevented very appropriately and effectively. As part of the next management, I need to do some investigations. First, I would do some basic investigations, starting with your full blood count. I'll check your kidney function, your thyroid function, and liver function. We'll check your cholesterol level and also your blood sugar level and a ECG to check your heart. We'll also do an urine test to check if you are losing any protein in your urine. Sam, in 90 to 95% cases, we can't find out why you have high blood pressure, which we call as essential hypertension. But if we find any underlying causes, then we will treat them first. Once the above investigations are done, we will check your 5-yearly risk for having a stroke or heart attack, and based on that, we will manage you accordingly. Okay? And as I already said that we have got some changes in your eye, so we will send you to an eye specialist for further assessment. But in the meantime, I would advise you to start some lifestyle modification. So please make sure you maintain an ideal body weight and also do some exercise, at least 30 minutes brisk walking every day. Have a healthy, balanced diet. If you're smoking, please try to stop it and maintain a safe limit of alcohol drinking if you are doing so. Once these investigations are done, and once I get the reports back, I will again ask you to come and visit me. Then we will talk about further management. I'll give you reading materials about everything that I talked about, and I will again talk to you soon. Do you have any question? Okay, so this is actually how we would do these kind of cases. We'll be very slowly, we will go into the detail. We'll not give too much information to overwhelm the patient, but everything should be connected. The main key steps, now obviously you don't need to do all of it. So your main key steps in here is to talk about why we have done home blood pressure measurement, and now why we are doing an ambulatory blood pressure monitoring, and what is actually ambulatory blood pressure, because that's your one task. The second task is the implication of hypertension. So talk about all the implications. The third task is investigation. So talk about the investigation. And lastly, talk about 5-yearly risk and sending the patient specialist. And you can just say that you would advise some lifestyle modification. It's not a task, but if you say, it's not going to hurt. Okay, cool. Any question with this case? Now, time to time, you will get this kind of cases in the exam where you don't need to do any history, physical examination, anything. Just management is the task. And you have to talk for 8 minutes. In that time, make sure you give some pauses in between. Ask the patient for understanding, which Dr. Titi has done very good. So that's important as well. So that patient doesn't feel bored, or you will see that your examiner is sleeping or snoring when you are talking. It happens. So don't make them very, very bored. That's also important. Otherwise, they will not know how to mark you because they were sleeping when you were talking. Okay. Any question? All good. Now let's do another case. So who was next after Dr. Ismotara? Dr. Anika and Dr. Karthi. So let's start with Dr. Anika and then we'll do Dr. Karthi. Okay. So Dr. Anika, if you can unmute yourself.
Yes, hello, doctor.
Hi, how are you?
I'm good. How are you?
Good. All right, so let's do a role play then.
Okay.
All right, so this is your case. It's a very important case. Now, when you are done, you can ask me to show you the ECG, and I will show you that. All right, so your 1 minute time just started.
Okay, can I start, doctor?
Do you want to see the ECG?
Just give me 2 minutes. Sorry, my kid came. I just want to go through the question again.
Okay.
Yes, I'd like to see the ECG.
All right, so this is your patient. Your patient name is David. You should start.
Hello, David. My name is Dr. Anika. I'm one of the doctors here today. How are you doing?
I'm not doing good, doctor. I'm just having this severe chest pain, and I don't know, I feel like I'm dying.
Okay. Can okay. Okay, sorry, I'm interrupting you, Dr. Ashan, because I'm a beginner as well. So I just want to ask, should I ask the examiner
Yes,
that if I can proceed?
Yes, it's a face to face. Okay.
Okay. Okay, David. David, would you excuse me for a moment? I would like to talk to my examiner, and then I will get back to you. Is it okay?
Yes.
Okay. Okay, dear examiner, I just want to ask if the patient is stable and I can continue with the history.
Please proceed.
Thank you. Okay. Hello, David. I would like to ask you a few questions. I just want to ask you, when did your chest pain start?
Just about half an hour ago.
Are you still having your chest pain?
Yes, doctor.
Okay, I will give you some medicine to relieve your chest pain, and then we will continue with the some more questions. Okay, David?
Okay.
Okay. Okay. So you said your chest pain started a while before?
About half an hour ago.
Okay, half an hour ago. And is it the first time that you have experienced such chest pain?
Yes, doctor.
Okay. Did you have any other symptom other than the chest pain?
What do you mean?
Did you have anything else, like you felt um, okay, can you tell me where exactly did your chest pain, did it radiate somewhere? Did it go, did you feel it in any other part of the body?
Yes, I can feel it in my neck and also my left arm.
Okay. And David, was your chest pain increased on walking or any other aggravating factor you felt?
It just happened half an hour ago while I was walking. So I'm not sure, doctor.
Okay. And do you have any other medical problems like hypertension, diabetes?
No, doctor.
Do you have any family history of any heart condition?
Yes, my mother had a heart attack.
Okay. And you have never felt any like you have never had any high blood pressure occasionally or any headaches, anything like that previously?
No.
Okay. Okay, David, I would like to talk to my examiner and then I will get back to you. Is that fine with you?
Yes.
Thank you. Dear examiner, I would like to tell you some of my ECG findings for this patient.
Yeah, go on.
Okay. So the ECG has a regular rate, and I find ST elevations in the anterior part of the heart in leads V2, V3, and V4 and V6. So anterior and lateral part of the heart. So I think this is ST elevations in V2, V3, V4, V6.
Okay, is there anything else?
Yes, I also see T wave inversions in leads V2, V3, V4, V5, and V5. And that's about it. And the rate and the rhythm is regular. Okay. Okay. So David, I would like to discuss with you some of the management. Explain for. Okay. So should I explain this to the examiner, doctor? Further management with the patient?
So explain with the patient.
Okay. 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 So David, I would like to discuss some management with you regarding your condition. And the pain you have been experiencing, we have performed an ECG for you regarding your pain and to diagnose your condition. And we have found some problem with your heart on the ECG. And ECG is an electrical recording of your heart. And we have found some problem with the with your ECG, which is problem in your heart muscle. For that, we would be referring you to a cardiologist, and we would be giving you some basic intervention at first, and then we will be referring you to a cardiologist for long-term management. Okay, doctor, I would like to stop here.
All right. No worries. You have got 1 minute time in your hand. That's all good, Dr. Anika. I know that you are a beginner. You are trying your best. That's the important part. And it's really brave to come and do the role play when you are very beginner. I would not even do that. So that's actually really, really appreciating that you are doing that. Now, there is nothing you need to think. When you are talking, you just remember that everyone is listening and you are the boss. Just remember that. Because if you think it that way, you don't need to think that what your examiner is thinking, what your role player is thinking. You are the boss of this station. So you act like that. Okay, so it's like just, you know everything because you know the management of MI. So just say that what is the management of a ST elevated MI. And if you can just say the immediate management, that's your task. So what you normally would do if a patient comes to you with a acute severe chest pain and the ECG showing ST elevated MI.
Okay. I was just confused that if I need to explain this to the patient or I need to explain it to the examiner. So I wanted to explain this to the patient, right?
Yeah, like your task is already written, like you explain management with the patients. There is no confusion with that, right?
Okay, okay.
Yeah, but let's say like whatever it is, even if it's to the examiner, what you would do to the examiner?
I would tell him like the basic management, like, we'll give the patient oxygen, then we'll give him nitroglycerine and aspirin and
Good.
morphine if he's in pain. And
Good.
if he's presented within the golden hour, which is like ideally 60 to 90 minutes, we'll transfer him to the cath lab for angiography. And if he's beyond that, then we can go for, streptokinase or anti-platelet agents.
Yeah, so say that you already know everything, right? So you
Yeah.
just need to say this thing to the patient. So that's about it. I know that you know the management of MI, so that's fine. Now we actually discussed this same case in our class. So go through that video again, find out what exactly we have to do in this station, and because this is actually one of the most commonly asked case in the exam. So it's so important and it's so vital for the exam that you need to be very perfect in this case, because some cases are like paid cases. Like everywhere it will come. If you're going for a MRCP exam, this will come. If you're going for a plab, this will AMC, this will come. This case, like it will come in every exam. So you have to be perfect in here. Now let me discuss again that how we would start in here. Okay. So this case, it's obviously in the ECG, we already know that this patient has got a ST elevated AMI. So the first thing that you do is to take the patient to the resuscitation cubicle. So start in that way. Always, like when I say that I am dying, Dr. Anika should say to me that I'm very sorry, David, that you are feeling this way, but we are here to help you. You are here with us. So we are going to try our best to make sure you are comfortable. So please let me find out that if you are stable enough, and then I will come back to you for further history. So obviously, if someone is saying that I'm dying, doctor, you have to say something in return. Otherwise, they will think in their head, oh no, I'm dying because my doctor is not saying anything. That's something not very good. So MI patient 30 minutes ago came to you, you can manage this patient and you're not saying something bullshit to the patient that we can save you, there is nothing to worry about. We have seen patient in here who comes with MI, same day, they go to their home with a stent inside. So those patients we have seen in Australia. It's fine. You're going to save this patient unless something happens that's not in your hand. So we will start in that way. Hi, John. This is Dr. Ashan, one of the doctors in this GP clinic. I understand from the notes that you are having chest pain. I'm very sorry to hear that, but please don't worry. Now that you are here, we are going to take care of you. Would you please tell me how severe your chest pain in a scale of 1 to 10? Doctor, it's 9/10. I'm very sorry. It must be very painful for you. Do you have any allergy to any medication? No, doctor. Well, I'm going to give you some strong painkiller. You will feel comfortable after that. Now, David, please excuse me for a moment. I will come back to you after talking to my examiner. So, dear examiner, I would like to know if my patient vitally is stable for further history. Examiner says, please proceed. Please stick to your task. You say in return, dear examiner, as I have seen in the ECG, my patient having a ST elevation in the lids, in the chest lid, most likely a ST elevated AMI. I would like to take my patient to the resuscitation cubicle, call my nurse, attach this patient to the ECG monitor, ask my nurse to do a ECG immediately. In the meantime, I will insert 2 large bore IV cannula. I will take some blood for cardiac enzymes and other bloods, and also start my patient with a 300 milligram of aspirin immediately. I will check his oxygen saturation. If it is less than 94, I would start with oxygen. And even after giving morphine, if still he is in pain, after checking his blood pressure, I would give him some nitroglycerin as well. So you say these lines because this is the management that you need to do. Now, if you don't have time for that, you can at least say that you would like to take the patient to the resuscitation cubicle, attach the patient to a ECG monitor. Now, obviously, you have already got a ECG. You don't need to do another ECG now. So just say that you would attach this patient to a monitor, and then you would start the patient with aspirin. If you only say aspirin and resuscitation cubicle initially, you are safe. Once you have done that, then you come back to the patient and say, thank you so much for waiting for me, David. Now, would you tell me a little bit more about the pain? So you have to ask a brief history from the patient. That means no differential diagnosis. Ask all the Socrates pain questionnaire and ask what is the associated symptom of MI. So do you have any difficulty breathing, any nausea, vomiting, any excessive sweating? Do you feel lightheaded? So these are main features or racing of the heart. After that, the next is just find out if the patient has got any risk factor of MI. And because you already know from the history that this patient cannot have PCI because you can't send the patient to a tertiary hospital and you are in a rural hospital. So you have to go for a thrombolytic agent. So no more PCI. So you have to also include if the patient has got any contraindication for thrombolytic agent. So after chest pain associated symptom, your next question will be, any medical condition have you got? High blood pressure, diabetes, anything like that? Are you on any regular medication? Do you smoke or drink alcohol? Any family history of heart condition? So these are the usual risk factor. We could ask about diet, exercise, all of those, which is not so important at the moment. Next, contraindication of thrombolytic agents. So have you had any bleeding in your brain recently? Any history of a stroke in the last 3 months? And also you need to find out that if the patient has any bleeding disorder, are you on any kind of blood thinner at the moment? Okay, so these are a couple of contraindication for thrombolytic agent. If you ask that, examiner will be happy. Once you have done that, you explain ECG to the examiner. The ECG explanation should always have a format. As we already discussed, what is the usual format? We start with P wave, then QRS complex, then ST wave, then T wave, then QT interval. Follow that format. In this case, you have got ST elevation in V1, V2, V3, V4, V5, V6, also lead 1 and lead AVL. So this is extensive myocardial infarction. Also, you have got quite significant T wave inversion in all the chest lead, right? So that's important. You have to say those things. Otherwise, like this ECG explanation will not be perfect and you will get low mark. After that, further management with the patient. Further management means that this patient in the GP setting, so what you are going to do for this patient, or this patient is actually in rural setting, you can say. In rural setting, the first of all, you would explain that you are having heart attack, explain what is heart attack, explain why it is very serious. We already discussed this case, so go through that, and then explain that what you are going to do. Immediate management, you just discuss that you have already given morphine, aspirin, nitroglycerin, and oxygen if needed. And then you talk about that because you are in a rural hospital, the best management would be to take the patient to a catheter lab and then just dissolve the clot or remove the clot by a procedure called coronary intervention or percutaneous coronary intervention. But because now we are 4 hours away from the nearest hospital, we can't do that. And every minute that we are wasting, it's killing your heart. So right now I'm going to call to the tertiary hospital cardiologist on call. I'm going to discuss about your case with him and we will proceed our further management based on that. Most likely we're going to go for another alternative treatment for this condition, which we call thrombolysis. In that case, we will give you a medication called alteplase or reteplase or streptokinase to dissolve the clot that you have had. Okay, we have already asked for any possible contraindication for that drug, which you don't have at the moment. So most likely we are going to proceed with that. Then at the end, make sure you give a lot of reassurance to the patient. Ask the patient that if he wants to call his friends, family members to be here. Okay. So that's how we should do this case. The management is only the immediate management of like monotherapy and either a PCI or thrombolytic agent. You don't need to go for long-term management in here. Clear, everyone? Any question with this case? You guys are doing really good because I can see that you have learned a lot already. So that's actually a good thing. Now let me take a 5-minute break and then we will do maybe another 2 cases. Okay. And we'll also have our serious risk assessment discussion. Thank you. All right, so who is going to do the next role play? Yes, Dr. Karthi, you can do it. You were next, right? So please unmute
Thank you.
yourself. Okay. How are you, doctor?
How are you, doctor?
I'm good, thank you. Okay,
Thank
so
you, thank
we're going to do another case now.
Yes.
Just give me a minute.
No problem.
So you'll get 1 minute time outside and then 7 minute 30 second inside. Okay. I'm going to
Okay.
show you this now.
Okay.
So your 1 minute time just started.
Thank you.
Now, you don't need to do this one. Okay.
Okay. Okay. Thank you. Yeah.
All right. So this is your patient. Your patient name is John. You can start.
Yeah. Thank you very much. Hi. Good evening, John. I'm Dr. Kirti. I'm your GP today. Is it GP setting? Yes. Okay. So.
Yes, doctor.
Yeah, please pardon me for one second. Dear examiner, could you please tell me this patient's vitals, blood pressure, pulse, and oxygen saturation?
Stable.
Pardon? Stable? Okay.
Patient is
Thank you
stable.
very much.
Yes.
Yeah, and I'm very sorry, John, to hear that you have a chest pain. Can you please tell me how bad is your chest pain out of from 1 to 10 pain score?
It's about 5 to 6.
Okay, is it all right if I continue, asking some information from you, or you want me to give you some painkillers?
That's all right, doctor.
Okay, thank you. And can you please tell me that the note says that you have a chest pain for the last 2 hours. Can you please tell me a little bit more about your pain?
Yes, doctor. It's like just I'm getting some strange pain in my chest. And it
Yes.
feels like something is squeezing my chest. It's not
Yes.
like more to the chest, but it's more towards my upper part of the tummy rather than the whole chest.
Okay.
So it's not the first time I'm getting it. It's just happening
Okay.
on and off 6 months.
Oh, all right. And at any time, have you been admitted to hospital and did any investigations?
No, doctor.
All right. And can you please tell me what are the any other associated symptoms that you said that you have severe squeezing chest pain? Is it on the, the bottom, lower part of the chest or in front of the chest?
It's mainly lower part of the chest, like mainly I would say part of the tummy.
All right. Yeah. Any other associated symptom like dizziness or lightheadedness or headache?
No.
No? Is the pain radiates anywhere into the neck
What do you
or
mean
the
by
shoulder?
radiant?
Does the same pain runs towards the arm or the shoulder or the neck?
No.
No? Okay. And is it associated with sweating?
No.
Do you feel racing of your heart?
No.
No. Can you please tell me what were you doing when you're getting this pain?
It just happens, doctor. Like sometimes I'll just sit on my couch, it happens. So I can't see any association with any kind of thing.
Okay, and not with food even.
Sometimes, yes, with food, like if I take a very spicy food, sometimes I can get it.
All right. Do you have any reflux coming up, the old food coming up into your throat?
I have that burping problem, yes.
Okay. Have you been taking any medication for that?
No.
No. All right. And can you please tell me anything which aggravates this pain, like walking or doing some work?
No.
No. All right. And is it? You said that it has been having you have been having this pain for 6 months, and is this pain? Is there any particular time of the day you get this pain?
No.
All right, thank you. And do you smoke?
No, doctor.
Do you drink alcohol?
Yes, almost every night.
All right, and yes, of course. How much of alcohol you take usually per day?
1 glass every night.
1 glass of what? It's wine or
Wine.
all right. Okay. And yes, with your consent, I will organize, if you like, I can organize another discussion because you're taking a little bit of more than recommended amount of alcohol daily. So I would, yeah, if you give me the consent, I can organize another appointment to discuss this. Is it all right?
Yeah.
Yeah. Okay. And yeah, do you take any other medication?
No, doctor.
Do you have any allergies, Mr. John?
No, doctor.
All right. And are you taking, do you have any other illnesses like high blood pressure, diabetes?
No, doctor.
No. What about your family? Anyone in the family has similar kind of illness?
No.
Okay. And how, have you done any surgeries or any problems in the past?
No.
No. Okay. Okay. And yes, thank you very much for your information, Mr. John. So give me 1 second. I need to speak to the examiner. Dear examiner, can you please give me the investigations of this
Which
patient?
investigation?
Oh, yeah. So first I need to get the ECG. Okay. And yeah, this ECG is appears the heart rate is around 75, and it is a normal rhythm with all with normal QRS complexes with which is followed by regular P waves, and the T wave is also normal, and it appears to be ECG appears to be normal with normal normal cardiac axis. I would say this is a normal ECG. So I might need to do in this patient full blood count and liver function test, kidney function test, and if possible to get the this Helicobacter pylori serology, and yeah, those things I need to do. And yes, those are the ones I need to do. I will be looking at whether there is any anemia in the full blood count, and the H. pylori serology, whether it is positive. In that case, I will proceed to do the, and I'll proceed to do the urea breath test, and liver function
Time
test
up.
will. Okay, thank you.
Okay. What's your diagnosis?
It looks like GORD, I think.
Yeah, very good. Very good, Dr. Kirti. So did I say it right, Kirti?
Yeah, Kirti, yeah. Thank you.
Kirti. Okay. All right. So, Dr. Kirti, you did very good. You are very calm and confident. You're doing really good. I would say that you have to be a little bit faster, because in like the speed that you are having, it is very good speed for usual GP practice, but not for the exam. For the exam purpose, you have to be a little faster, because I'm sure that you will not be able to finish the task in time. So
Okay.
in case, like, be a little faster and just have the rhythm, and that should do your trick. Now, in this case, like in your case, like I feel in the history, you haven't asked many differential diagnoses for chest pain, because your task is history, investigation, and diagnosis DD. It's not like a very large amount of task. So the history should be extensive, which means that obviously you will ask all the chest pain question, which you have done very good. Associated symptom you have asked, that was also really good. But the differential, especially the lung causes, so ask about pneumonia, pulmonary embolism, ask about pneumothorax, okay? Ask about musculoskeletal symptoms, ask about herpes zoster, ask about any neck pain, any back pain. So all the differential diagnoses should come in here, because that's also important. So most of the candidates usually get it wrong in here, that they don't remember the DD. So the 2 minute time to get in the outside, you only think about the differential. If you do that, you actually do really good in the history, because differentials are always important.
Okay.
So, and also, like in this case, like if we would look into this case, like it's a middle-aged patient, squeezing pain, 2 hours, it seems like a MI patient, right?
Yeah.
Now, the case turned out to be a reflux case, but in a normal situation, we would think it as MI. So you should also think it as MI in the exam. So you just say that you would like to take this patient to the resuscitation cubicle, attach the ECG monitor, and at least you would like to do a ECG test. You don't need to start the patient with aspirin or anything if you are not sure, but at least take the patient to the resuscitation cubicle, because this patient sounds. Sorry, some of your microphone is on. I will just mute everyone. So that's actually what is important. You have to make sure that you are a safe doctor, because that's the safe doctor would do in this case. The case can turn out to be a reflux case. That's fine, but you did the right thing. So then you will start asking all the chest pain questions, everything that you asked in the history for a chest pain case. Investigation ECG explanation was fine in here. This was a normal ECG. The most likely diagnosis will be reflux, and then you have to give differential. Now, if you don't ask DD, from where you can give your differential, right? So that's the thing. If DD is a task, your history should have many differential diagnoses. And also, like in the chest pain cluster, if investigation from examiner is a task, you don't need to ask more investigation. If you get ECG, that's fine, because they actually want ECG from you, not other investigation. If you don't say Helicobacter pylori investigation, urea breath test, that's fine in this case. Okay, but ECG is the main one in this case. So as long as you're saying ECG, you're good. So don't waste a lot of time in here with explanation of the investigation. Rather than that, go to the diagnosis and DD. All right, so that's one of the other that the cases turns out in many ways. So in exam, things are not always same. That's what I wanted to show you. So sometimes you can get a normal ECG in the exam also. So you have to be confident that, yes, I know what I'm doing. And Dr. Kirti has done really good with that. Okay, so I feel like we have done a lot of cases already. Now let's just finish with a serious risk assessment. Pancreatitis can be a differential diagnosis, Dr. Chamalika. Okay, because yes, epigastric pain you might need to add some more differential diagnosis if you get a epigastric pain. Like you will end up taking peptic ulcer disease, you will take pancreatitis, hepatitis, cholangitis. So those differentials will also come in this case. Now, one other thing I found that 1 glass of wine, it is not high in Australia. Like if you take 100 ml of alcohol or 100 ml of wine every night, it is normal. It's just one standard drink. A normal male patient can get 2 to 4 standard drink every day in here. So that's not actually a very high amount that he's taking. So in that case, don't say that you want to talk about alcohol, because that patient will get angry with you. Oh, I'm following the Australian health guideline. Why does doctor want me to like talk about alcohol? Okay, this happens in here. But if it causes complication, like if the patient gets pancreatitis out of it, then obviously you have to ask him to stop. But if the patient would say 1 bottle of wine, then that's something which is we are worried about. 1 glass of wine, that's okay. Let's talk about serious risk assessment, and we will end with this one. So serious risk assessment is one of the other case which comes in exam frequently. And then there is other case which we will discuss in psychiatry, that is called hypertension non-compliance case. There is also another case which we haven't done. That case usually we do it with dementia because it's a little connected with that. So that's all about serious. If you can do up to this, there is no case which we haven't done. So you are a GP, middle-aged man, come to you to have a consultation after his brother went for coronary bypass 2 weeks ago. He is obese, no other past medical history. Your task is to take a focused history from the patient, physical examination finding from examiner, explain what will be the initial management for this patient. So the history for such a question where patient come to you after a coronary bypass surgery of his brother. So you will obviously need to find out what actually is his concern. So hi, John, this is Dr. Arshan. I'm one of the GP in this clinic. It is very nice to meet you. I got to know from the notes that your brother had a bypass surgery 2 weeks ago. I'm very sorry to hear that. How is your brother doing now? That is very important to ask. Okay, it seems irrelevant, but trust me that you are making a rapport with the patient by doing that. Always ask these things. It's not unnecessary. It is something which is important to show that you are a caring doctor, not just for the patient, but for the whole person as a family also. So if a patient say, my father died a month ago, and if you ask a question after that, it seems so rude. You should say that I'm very sorry to hear that, how you are dealing with it. Okay, so that's your usual response after hearing something said from a patient. So those kind of communication approach, if you don't know how to do it, you will end up getting a fail mark in the exam because of your approach, and you will never know what you have done wrong. Okay, so make sure you have that approach in your head always. So after that, say that, so can I please ask you that what is your main concern today? Yes, doctor. So I don't want to end up like my brother. So I want to know that what I can do to make sure I don't end up getting a heart attack like my brother. I understand. And I really appreciate, John, that you are coming for this. There are a lot of patients who would not come to discuss about it, but I'm happy that you are doing it. It is really good. Now that you are here, I will try my best to make sure that you don't get heart attack, or at least we will know where are you at the moment. So let me ask you a few questions to find out your risk first. Is that okay with you? Yes, doctor. So we follow the ABCDEFS format for risk assessment. So A for alcohol, B for blood pressure, body weight, C for cholesterol, D for diet, diabetes, E for exercise, F for family history, S for smoking and stress. Now, obviously, we would not start with alcohol, blood pressure initially. We can start with, first you can ask about some symptomatic question related to cardiovascular system. So you can say that, well, how are you doing generally? Do you have any chest pain, any difficulty breathing, any racing of your heart? Okay. Any problem with your vision? Any pain in your leg when you walk? How about your water works? Any reduced output of urine recently? So a couple of CVD risk factor questions you can ask, like symptomatic questions, chest pain, difficulty breathing, racing of the heart, feeling dizziness or lightheadedness, those kind of stuff. After you have started it, then you can ask about, do you smoke or drink alcohol? Do you have any medical condition like high blood pressure, high cholesterol, or diabetes? How about your typical daily diet? Do you take a healthy, balanced diet, kind of exercise? Any family history of heart condition, diabetes, or high blood pressure? How about your home? Who do you live with? Is there any stress at your home? Do you do any work? Is there any stress at your work? Any financial issues? Any other past surgical or medical history? So that's your history in this case, nothing more than that. Okay. Once you have done that, then thank the patient, go to the physical exam from examiner, ask about general appearance, especially look for any sign of high cholesterol like genital asthma, xanthoma, corneal arcus. Ask the pickled, then vitals and BMI. Very important, asking about vitals. Why? You will get blood pressure from here. BMI, you will get if the patient is obese or not. So two important risk factors. You will do a complete cardiovascular system, respiratory system, and this quickly abdominal examination. Your office test will be urine dipstick, BSL, and ECG. In the urine dipstick, you are mainly looking for if there is any protein in the urine, blood sugar for diabetes, and you will obviously do an ECG as part of a cardiac health checkup. And at the end, you can also ask from the examiner, is the cardiovascular risk chart available or not? So that's your physical examination from examiner. Now, we haven't done respiratory system or abdominal examination yet. When we will go to that cluster, you will know how to examine them. Explain that from history and physical examination, John, I have found some risk factor, like you have high blood pressure, your body weight is higher than normal, and also you have diabetes. Your diet contains fatty food rather than healthy, balanced food. And also you have been smoking for the last 20 years. All of this put you on some risk of having a heart-related complication in future, especially a heart attack or a stroke. But please don't worry, we can prevent these complications by adopting a healthy lifestyle from now onwards. So I would like to advise you to cut down your alcohol to safe level, avoid smoking, try to maintain ideal body weight, take healthy balanced diet, do some exercise, and try to avoid a stressful work. I would also like to arrange some investigation, especially full blood exam, your kidney function, and ECG, your blood sugar level and lipid profile. Once we have done that, then again we will put this in a cardiovascular risk chart to see that how much you are having the risk and how promptly we need to treat you to prevent those complications. I will again review you once the results are back. In the meantime, please make sure you start doing those lifestyle modification. If you need any help, we can always send you to some allied health professional. We can send you to a dietitian who can help you to have a good, healthy, balanced diet. We can send you to an exercise physiologist who can also show you some of the cardiac exercise which can be helpful for you. If you want, we can also arrange some sessions to discuss about your smoking and alcohol. I want you to know that you are not alone in this journey. You came here to get help, and I'll try my best to make sure that you get that help and you get a healthy life. Okay, so say something nice and nice like this, they will be happy. Any question, guys? And yes, Dr. Amit, you can also ask about waist circumference. That is also a good one. Then there is another case, the same thing, but in that case, they will give you everything in the stem, like you are a GP, a 57-year-old man coming for a follow-up. He came previously after his brother passed away from heart attack 2 weeks ago. He's a smoker, and blood test shows 160/100 blood pressure. Lipid profile cholesterol shows 8:1 ratio. You have to estimate the cardiovascular risk to the patient. That means you have to explain, first you have to plot this reading on this chart, and you have to explain what is this cardiovascular risk chart is, and explain further management to the patient. So only thing that you need to know how to plot this on this cardiovascular risk chart, which I'm sure you already know from MCQ. If you don't know, then let me discuss it. When you get a CVD risk chart, you look at the chart first. So see that this side is the women and this side is men. So our patient is a man, he is a smoker, and we need to know that what is the age of the patient. He's 57. So this is the age group he is on. So we are mainly looking into this area, right? So this is the area we are looking for. Once we pick up that, then on the y-axis, we have our systolic blood pressure. On the x-axis, we have cholesterol HDL ratio. We know from the stem that systolic blood pressure is 160 and cholesterol HDL ratio is 8:1. So first of all, find out where you want to put 160. Now, this is actually something to learn about. So let's come over here. So see this systolic blood pressure 120, 140, 160, okay? It's not the highest limit of this box. So if we are talking about this box, the highest limit of this box is up to 130, not 120. Same, this one, highest limit is 150, this one 170. Okay, so in that way, so just add 10 with what you see here. So that's your highest limit. And in case of total cholesterol HDL ratio, you can see 4, 5, 6, 7, 8. So the highest limit of this box is 4.5, not 4. This box, 5.5, this one 6.5, this one 7.5, this one 8.5. Okay? So that's actually the tricky part in this risk chart. Once you know that, then you just need to plot it. So plot 160 in here. So 160 is here, right? So 160 will fall in this area, obviously. Then you go to the cholesterol HDL ratio. You know that it's 8. So 8 means it will fall here. So you go up and you meet here, right? So this is the red box where our patient falls. Now you compare here that what the red color means. Red color means that patient having more than 30% risk of having a heart attack or cardiovascular risk in the next 5 years. That means he's a high risk patient. So you just need to explain all these things to the patient, that how you ended up getting this thing from the CVD risk chart. And then just explain what we have done in the previous case. So if I were you, I would say that, John, let me discuss about this cardiovascular risk chart with you. If you look at the chart with me, you can see that in the right side, this is the chart for men, and the left side, we have the chart for women. And this chart is mainly for patients without any diabetes. And also you can see that there are some portion for a smoker population and some for non-smoker population. In the middle, we can see the ages. So because you are a 57-year-old male and you are smoke, I'm mainly looking in the second part from above. Now in this chart, we mainly put your top blood pressure, which we call systolic blood pressure. In your case, it is 160. And also we put your cholesterol ratio in here. So we mainly measure your risk based on your age, your smoking history, your blood pressure, and your cholesterol value. And once I have done all of it and I plotted it on this graph, you put into this red box. And I compared this red box according to the chart, and it shows that the red color means you have more than 30% of risk of having a cardiovascular issue in the next 5 years. And more than 30% means it's a very high risk. I'm very sorry to tell you that, but it's not that I'm scaring you. And the good thing is that now we know your risk and we can treat you accordingly, and we can prevent any complication that could happen from this high risk situation. Okay, so just explain very simple, nice and slow. That will be the only thing that you need to learn here. That learning how to talk to a patient without explaining too much, that is a quality that you need to build up. Okay, and that happens with a lot of role play. Eventually, you will know what to tell. All right, so that's all about the CVS risk assessment, guys. Any question? I did not get your question, Dr. Omin.
So there is a part at the bottom, 35 to 45 years. Is that only for Aboriginal, not for normal population?
No, it's mainly for Aboriginal because normally from 35 to 44, we don't measure the CVD risk. The CVD risk, normally we do it from 45 up.
Okay, and it's higher for Aboriginal.
Yes, that's why we do it from 35 years.
All right, so thank you.
No worries.
Doctor, I have one question. Can I ask you?
Yeah, sure.
So, doctor, this additional CVS case, can you find out in our software?
Yeah, you can.
I'm the
These
previous
cages,
batch student.
these cages are actually in your cardiac role play session in that note. Okay.
Okay. Doctor.
It's not in your CVS note, it's in your cardiac role play session note. So you will find out in those like there are, I think, 200 pages. So you will find it there. What we are doing now, that we are actually moving these questions that we are discussing now here, especially the new things, we will put it in your cardiac note as well. So you will get these notes in your cardiac note from now onwards. Okay.
Okay, doctor. Thank you so much.
No worries.
Schedule, like weekly schedule for the whole course, like what topics we'll be going through.
Yes, you normally get it before, usually you get it in before 2 to 4 weeks. Like normally we give 1 month or sometimes 2 weeks schedule in your group. Okay. You haven't got it yet because we are just finishing the 2-week session now, but you will get it in like within few days, that what's going to have the next 2-week session.
Okay, thank you, sir.
Any other question about the course? So I hope that you guys are enjoying the session so far. And obviously, like you can see that how the course is going to run. This is usually the pattern that we follow. In one, we take one topic, we finish it in a way so that nothing is there, and you get confidence in that part. And in that way, we'll finish the whole sessions in a 5-month time. That's why we need 5 months, because we can finish cardiology in one class. Trust me, I can do that. But it will not have any impact on your head. You will not remember anything after 2 months. But the way that I'm doing now, there is no way you will forget anything. Even if you want to forget, there will be something in your head from all this discussion. Okay? So having these 5 months, it is necessary. It's not like it's a luxury that you have been given. It's a necessary thing for your preparation. And that's why you can see that why our students pass in this rate. In July, we had 8 candidates who passed the exam. I'm sure like there is no other courses where this much students have passed in 1 month. So there is a reason why our candidates thrive in the exam. So make sure that when you make your decision, you make the decision appropriately. Okay? It's about passing the exam always.
Do you know how many total candidates all over appeared in AMC clinicals and how many total passed?
No, doctor, we can't actually, the AMC does not say that, unfortunately. They don't give us a statistics.
Thank you.
Hi, Dr. Arshan. Can I ask a question?
Yes, Dr. Chamalika. Is it Dr. Chamalika?
Yeah. Yes. Dr. Arshan, can I know like how the online mock exams are held?
Online mock exams are like in the course, you get some mini mock exams, which is not like a full 16 station mock, but you get some mini mock exam. There is another online mock exam, which is a 16 station mock test. The 16 station mock test is not included in the course because we do it every month, usually second and third Sunday. So for that, you get it in, you just need to ask us that you want to go for the online mock test, maybe on September or October. We will give you the payment link and then you'll just get enrolled for that. So that's a something which our students do with a reduced price. Okay. And there is also another thing which we are going to introduce from this batch that most of you are going to enroll. That is actually was our plan for a long time, but you guys will be the luckiest one, I feel. So we are going to arrange some mock exams, which will be like, especially on online, we will take 16 students for doing role play with another 16 students, which means that you guys will be taking your exams, you will give feedback, but in an exam environment. So that's what we are planning to do. So you will do role play with each other and you will rotate each other. And we will organize that. Our examiners will be there to see how you are doing. But this is how you will also get some experience about the exam environment in the course. So that's our plan for you guys. We will hopefully can implement that once the course starts fully.
Thank you so much.
No worries. And I don't know who asked it, but Dr. Arshan, what is the best way to take maximum benefit from your course? Like listen to your videos and then practice role playing. My advice is always that if you are planning to appear early, just after finishing the course, join the live session. That's the most important thing. Joining the live session keeps you on the loop and you know what you are doing. You don't just go through the recordings. When you start listening to the recordings only, the offline things takes a lot of time. You waste a lot of time. Sometimes you pause the recording and then waste one hour talking to your friends, your families, and then come back. You go for your dinner. You do some stuff, like you always will lose some time, which you are getting in 2 hours in live session. You will waste 5 hours watching the video. So I always say that the best way is to come and do the live session and finish it, and then do the role play. Just read the note one time. You already know what you have to do from the live session. You read the note, your study buddy read the note, and then you do the role play. Okay. If you need some extra help and you want to remember, like, well, this case, Dr. Arshan has said something initially, which I want to know, then just go to that part of the video and listen to it. So that's my idea to get maximum benefit, and you don't waste a lot of time in that way. Now that depends, Dr. Anika, that how much hour you can give for this study buddy. I would say that at least divide your time. If you are not working, if you're only studying and you are appearing in 6 to 7 months, in that case, in the morning, you do role play with your partner. In the afternoon, or let's say afternoon, if you want to read, then in the afternoon, do physical examination on your partner or anyone else. And then at the evening, just read by yourself. So that should be your plan. If you are working, then that's actually tricky, because then what I would say that make one day for just reading, then next day do the role play in the evening. Okay. All good. So I hope that you guys are enjoying the session. There will be another free session with you guys on Saturday on pediatrics. So that will be our end of 2-week session. If you're still planning to enroll the course, make sure you start doing that now, because by this time you should know how we take the classes. So don't wait, because we will start the course immediately after this 2-week session is done. And this is actually part of the course also. So the next class you don't want to miss. So make sure we will have our orientation session also. So I would advise you to, if you are planning for the course, then start enrollment now. Yes, Dr. Priyanka, you have to do physical examination in face-to-face exam on a patient. In online exam, you don't need to do that. You just explain what you are going to do. And Dr. Samya, if you were in second batch of our course, then I think like it's been a long time. You might not be in the loop at the moment. I would say that if you already did the course, then join our weekly role play session, which taken by Dr. Cynthia, and then just listen to the recordings of our theory sessions. Okay, that's the best approach rather than joining the course again. Or if you want to join the course again, that's also okay. In that case, you can just get everything at the same pace. If that's what you're planning, that's also not a bad idea.